All right, welcome back. This is still JKLive. I'm Victoria Rubadiri. We've taken a slightly different form for the show. We are at Kibabi University in Bungoma. Super excited about this conversation ahead of World AIDS Day tomorrow. A very critical, important report is going to be launched tomorrow that gives us insights on the new HIV infections in the country, deaths, some of the interventions that have been put in place, the issue of funding as well. And I have the experts sitting here with me to help unpack all of that. As we speak, about 1.5 million people live with HIV in this country. And a lot has been done to keep those numbers down, to make sure more of them are on treatment, and probably most importantly, to prevent them from contracting HIV. And as we get this conversation started, allow me to introduce my panel once again. To my closest right is Dr. Ruth Laibon Masha, CEO of the National Syndemic Diseases Control Council. Next to her is Frederick Nyaga, who is the founder and chairman of Men Engage Kenya Network, or MENKEN. And we also have Dr. Chris Baraza, a gynecologist and health systems expert and chief of party for USAID, Imarisha Jamii Project in Turkana. We also have an extended panel who I'll introduce right now. We have the Deputy Governor of Bungoma County, Jennifer Mbaitani, and she's also a champion of women's rights and matters, GBV, FGM, and teenage pregnancy. And of course, she'll be telling us a bit more about what they're doing here in the county of Bungoma. We also have Dr. Medine Sehayu, who is the UN AIDS Country Director, and also joined by Mwangangi Mwania, who's the head of AIDS Control Unit in the Ministry of Interior. And we also have Rose Otaye, who has lived with HIV for decades now and will be letting us know what her experience has been like. And as I promised, we have a full auditorium here in the main hall in Kibabi University with the students here to share their experiences and just what they think about this HIV situation in the country. But let's get to the conversation. Dr. Masha, let me begin with you, because we're anticipating this report that's going to go deeply into where we are as a country with regard to HIV. I had this conversation with you a couple of weeks ago on Sunday Live on Citizen TV. Your biggest worry was the new HIV infections, particularly when it came to the age bracket of 15 to 29. As it stands, what are the new infections, HIV infections, for this year?
Thank you very much, Victoria. Indeed, tomorrow is the World AIDS Day, which we all look forward, because it's a day we celebrate most of the people we are living today with HIV, for their courage, for their resilience, but also we do remember those we have lost to the epidemic. So last year, which is basically the report we are launching this year, we experienced two things. One is that for the first time in 10 years, we saw the new HIV infections increasing. And this is really worrying, because we have really been making progress as far as new infections are concerned. So we had about 34,450 new infections. And of these, about 52% were from young people, age 15 and 29. And of course, majority concentrating between the ages of 15 to 24. Another key thing that has happened is that we also saw the increase in number of AIDS-related deaths. So in 2020, we had about 19,400 AIDS-related deaths, but then we got almost 2,000 more in 2021. So what is happening currently is that the numbers we are having for new infections are almost outspacing the ones we are putting on treatment. And so what it means is that we have more than, most of our population, more than 50%, living with HIV who are older persons from the ages of 35 and above. And then again here, we are saying that we have new infections starting from younger people. Then again, these are same young people who also are in the reproductive age. They are also going to get married. They are getting babies. We had 5,120 children born with HIV. So this is where it presents a challenge. So the new infections are happening in a period where we are also struggling to get commodities. We are aware across the world the resources available for HIV have also reduced significantly. Yeah. In Kenya, last year we had a budget deficit of about 10 billion just for commodities. And so what does it mean? It means that as a country we must do two things. One, we must stop the new HIV infections. Number two, we must also look at our supply chain and look for our own resources so that we are able to buy those commodities. I know you've been seeing on the press, and one of the commodities that is really, really key for this response is condoms, for example. And those condoms are needed not just for HIV, but for preventing sexually transmitted infections, pregnancies that are unintended, and of course, HIV. But now, if we don't have sufficient resources, we begin to trade off some of these essential commodities that are required for prevention. And therefore, we can then not sustain treatment because the numbers will then outweigh the resources.
So what would you say are the key drivers, especially when it comes to the new HIV infections?
So we see a couple of issues. One, we see a challenge of what you call systemic factors. Okay. And these are factors that make an epidemic become more pronounced within a community. I want to single out sexual and gender-based violence, especially among children. Last year, we saw an increase of the cases of children between the ages of 10 to 14 who are sexually violated. It's not a good thing. Again, majority of the cases that we are seeing for sexual and gender-based violence are occurring for the young people between the ages of 10 to 19. Those are adolescents. Then we also have a big problem as a country of adolescent pregnancies. And adolescent pregnancies are also as a result mostly because you're not seeing these small girls being able to give sexual consent as a result of, again, sexual abuse, exploitation. And then finally, we see that we have a bigger challenge with alcohol and drug abuse. And this is a challenge especially for boys, especially for men. We started a program of supporting those who are injecting drugs. In 2015, we had about 45. Last year in the program, we have around 8,800 of them. And injecting drug use is one of the issues that we have that actually becomes a challenge for any epidemic, especially where people are sharing needles. Right. So those are some of the things that we are seeing being prevalent and driving the epidemic.
Fred, let me bring you in here, because when we talk about drivers, SGBV, men are the main perpetrators. When we talk about teen pregnancy, these girls are not getting pregnant on their own. And then, you know, drug abuse, you've just heard from Dr. Masha, is primarily affecting the young men. So how are you engaging them? How should they be engaged to help tackle some of these issues?
Thank you very much, Victoria. Yeah, it's true that when it comes to issues of drug abuse, men are ahead, they are taking lead in that. And it's also, as you have said, true that for every pregnancy that you see, a man is involved. Even if it comes to issues of IVF, they are the donors. They're the ones who are going to be involved. It takes two to tango. So how should we change this scenario? One of the things that we need to appreciate is that there are factors that are making men to behave the way they do. Mm-hmm. How are we bringing these men up, the boys that we are talking about. It starts right at home. What messages are we passing to the boys as we are bringing them up? As the parents, are we available for these boys, particularly the men? Are they present in parenting? You agree with me that most of the times, the aspect of parenting has been left to be done by women, and men are actually absent. We keep on saying a good number of men are what we call IDPs, internally displaced parents. They are not there. Where they are, we don't know. Others are suffering from what we call TB. Here we are not talking about tuberculosis, but too busy. They are too busy doing nothing. But they are not available for parenting. And therefore, many of these boys are growing without good role models. They cannot see a good father or even a good uncle or a relative that they can emulate. Of course, we're not saying that all men are away. Right. We also appreciate that there are men who are available and ready to mentor the young people so they can be able to do things differently. Leaving the aspect of parenting, these children, when they are not with their parents, who are they with? These days we see that because of maybe changing economic times, you find like the middle class, upper class, they get people to come and take care of their children as they go to work. Mm-hmm. And therefore, we have a scenario where we have sired children, but we are not bringing them up as parents. Other people are doing it. And most of the times, you find that some of these people who are being brought in homes to take care of children are not necessarily parents themselves. They may not even have brought up any child. So their children bring up other children. Then when you go to the community itself is showing, it's like accepting some of these negative things. They have become normal. If you're talking about gender-based violence, right. How many times have we seen people coming up from the community and saying, we are not going to accept this? It's rare. Most of the times, even when it happens, people want to protect the perpetrators and to blame the victim.
So how do you address that?
Now, to be able to change this scenario, we are saying, one, we need to start at home. Mm. Then, from home, we need to move a step further. Can we move to the community and ensure that we don't normalize things which are negative? Number three, these children, these boys, they are also in school. What type of messages are getting in school? Many a times we have been talking about trying to introduce age-appropriate sexuality education. But parents, the community, the church leaders, they go up in arms. Because according to them, maybe they understand when we talk about sexuality, we are talking about introducing children to sexual practices, right. Which is not the case. We are trying to talk to them about issues to do with their bodies, how they are supposed to take care of themselves, how they are supposed to behave if they are attacked, and so on and so forth. So we should also go a step further and introduce the right education in schools. Yeah. Leaving the schools, what about at the policy level? You realize that Kenya, just like many other countries, we have very good laws, policies, which are supposed to protect people against gender-based violence. For example, we have the Protection Against Domestic Violence Act. But do we really use it? Are people aware that they can actually report when they see some of these things happening? The laws are there, but are we utilizing these laws? Are we protecting the children? Are we protecting the survivors.
So implementation is
Implementation is another challenge.
Yeah.
We couldn't be having the laws.
And we'll come back to more solutions, Fred. Let me bring in Dr. Baraza really quickly, because when you look at the numbers, in terms of new HIV infections, women tend to be the bigger number. Why is that? Why is that the case in terms of them bearing that burden?
Thanks so much for that, and thanks for this session. Indeed, women have faced the brunt of most health-related issues in the community. And there are multiple factors that influence this. Some are cultural, things to do with early sexual debut. Actually, we find that the sexual debut in our population is going lower and lower from probably 17 years. Now we are talking about 15 years amongst girls. It's slightly usually higher amongst boys. And of course, ladies, women, or girls mature much faster during adolescence compared to boys. So they'll be more attractive to a little bit older men. Therefore, you find that they'll have an earlier sexual debut. And then some of the other cultural aspects is the expectations of the society. We are living sometimes in a patriarchal society that expects women, or rather girls, to get married and bring some little coins to the family. And therefore, they end up actually not going to school. So again, engaging in sex much earlier, getting married much earlier. But again, there are also what we call biological factors that influence that. And without really going into a lot of medical issues, but the anatomy of the female is more predisposes them more to get HIV compared to a male counterpart. And therefore, that means that the risk of a lady getting HIV is much higher. But then there's another aspect of it, because the women are the ones who actually carry pregnancies. So there's another risk that we have of transmitting the infection to the unborn child. So you find that again predisposes that, because if a woman gets HIV, then they're likely to if nothing happens, actually they're likely to transmit the infection to the child. But let me just talk a bit more, Victoria, about the pregnancy issue, because it's becoming an epidemic.
Yes, it is.
And as right now, as we are talking about the triple threat of HIV, gender-based violence, and teenage pregnancies. And I'll just share with you an experience I had when I was about 33 years old. I met one of my former classmates. I'll call her Naske. That's not her name, really. She was carrying a baby. I was also carrying a baby. The difference between me and her was that while I was carrying my firstborn, Naske was carrying her grandchild.
Wow.
Yeah. It's a true story. It's not hypothetical. It's a true story. So the question that I asked myself was, of course, I reflected over this and remembered this lady. She used to be very smart in primary school, but she was from a dysfunctional family because she was staying with the dad. The mom had actually moved out, a single parent, and the dad was a drunkard. Okay, so her future got sealed at some point because she had no option but get married. So what that means is that if we don't do anything about Naske, she'll get exposed to HIV. If we don't do anything about her, by the time we hit 45, she'll have a great grandchild. And chances are, my son will not even be in high school, for that matter. So he will not even think about getting married, for that matter. So it begs the question, really, how do we manage this? Of course, it's clear, documented, that the younger a girl gets married, the more likely they face intimate partner violence. That means violence from a close relative, or violence from the husband, actually, for that matter. So this, again, a lady who is more exposed to intimate partner violence because she doesn't have the know-how of how to protect herself. So it's a very intricate relationship that we're talking about here in terms of managing IPV, or rather GBV, managing HIV, and again, at the same time, managing adolescent pregnancies, for that matter. Yeah.
You know, Dr. Masha, let me bring you in here because you mentioned something interesting. Deaths have gone up. And when you look at those numbers a bit closer, you realize that most of those deaths are men. Why is that the case? And also testing, men knowing their status is quite low. What leads to more men dying from HIV and AIDS?
Thank you. One of the key challenges actually globally, even as the report for the whole world was being launched, was the issue of men. And in Kenya, in 2021, we had about 8,270 men who died from AIDS-related deaths, and these were 30 years and above. So these are men, some of them represented here, working class, who have families, as compared to around 6,902 women of the same age. Now the challenge is we get men too late. First of all, as you said, is testing. Mm-hmm. Secondly, even when we get men to tests, they sometimes do not stay on treatment. Mm. And therefore, they don't get virally suppressed. And therefore, we lose them to AIDS-related deaths. Secondly, is that we also lack a space to actually get men the way we are able to get women. The women come to the facility because they are coming, they have a baby. And women generally tend to have better health-seeking behaviors than men. And it boils back to what Fred was saying. There must be something we must deconstruct even about health-seeking behaviors of men if we have to save men from AIDS.
Hold that thought, Dr. Masha. It is a hot one, but we need to take a short break because we need to pay our bills. We'll be right back. Stay with us and keep the conversation going on social media as well. We'll be back.